Hello, good morning. Welcome everybody to our third Ensuring Equity in Aging webinar. Today we're focusing on culturally informed policy and programs, the culture of LGBTQ older adults. I do want to share that we have live stream captioning available through Zoom on the bottom of your screen. Just hit the CC button. You can access that closed captioning. The recording from today, the slides, and our transcripts will all be posted on CDA's Equity and Aging Resource Center, and we'll also follow this webinar up with an email with links to everything that you could need, including resources and registration for next month's webinar. You can also watch the video on our YouTube channel. Throughout the presentation, feel free to enter any questions or comments you have into the Zoom chat box. And if you're accessing audio only through the phone and you only have access through the phone, and you'd like to ask a question at the end of the presentation, go ahead, press *9 on your dial pad, and it'll raise your hand in our chat box. And for any time you'd like to reach out regarding these webinars, CDA or Master Plan for Aging, you can send us emails at engage@aging.ca.gov. Next slide. And every first Wednesday, we'll be offering these webinars at least through June 2021, always featuring state and local speakers with expertise in cultural competency, equity program, and service delivery planning and policy as well. Next slide. And so next month, February 3rd, we have our fourth webinar, Culturally Responsive Services and Care Within 4 Black Elders. You can register for that on our website, and it'll also be included in the follow-up email to all of today's participants. I am going to go ahead and hand this over to Kim McCoy-Wade, the Director for the California Department of Aging, for welcome and introductions.
Good morning and welcome. And I'm flagging for our team the captioning question in our chat, looking for some help with captioning. So if we can jump on that, please. Welcome everyone to our new year, where we are starting where we should always start, with equity and inclusion. And I am delighted to be joined by such incredible leaders and champions and trailblazers in this field of LGBTQ+ and aging. I want to say, we have to all acknowledge the moment we're in right now with COVID, one of incredible suffering and challenge. Yes, we have the hope of the vaccines on the horizon and arriving for our elders in nursing homes and assisted living as we speak, but it is such a tough time. And just, while it makes it hard to do anything but do that, we also know all of this has to be driven by equity, and we have to come out of this more committed, more accelerating this work of equity and aging. And so I actually think it's right on time that we start the year, we get through this COVID terrible time, focused on equity and focused on inclusion. I also have to say, it's also ending up being the day where we're launching the Master Plan on Aging, where we have very much strived to include and not include equity, bake it in is the watchword that our equity work group charged us with. Not sprinkle on top, bake it in. And so that's what we are trying to do in everything we do, our day-to-day work, our COVID work, and our strategic planning. So really, this morning is bringing it all together before we do the master plan launch at noon. So after you finish this webinar, please come back and join the Secretary Galley at noon for a broad 10-year plan for really transforming aging. And so speaking of transforming aging, look at this great panel we have here with us. I will do a brief introduction of their long careers and get out of the way so the discussion can really begin. Jenny Pardini is a community education advocate with legal assistance for seniors and a Medicare expert, among other things, is part of our HICAP program, Health Insurance Counseling and Advocate. Thank you, Jenny, for your service. I hope you survived open enrollment the last quarter and came through that. Karyn Anderson is known well to me. I used to live in Oakland and very familiar with her work with the United Seniors of Oakland, Alameda County Senior Services Coalition, and Alameda County and Oakland Commissions on Aging. And also, of course, coordinates the Lavender Seniors Friendly Visitor Program, which so many of us know and are so inspired by. And last but not least, and actually I think first today, will be Karyn Skultety, who is the Executive Director of Openhouse and an expert and specialist in geriatric psychology. So we really do have a terrific panel, and I really do want to let the conversation begin, and I will stay with you as long as I can to hear and to learn. And I'm thrilled to see the count rising up to crossing 300, a record number, and the captioning coming into play as well. I see it now on my button as well. So we are good to go. And with that, I will hand it over to Karyn. Thank you.
Good morning, everyone. Thank you so much to CDA and Kim and Amanda and everyone for inviting and including me on this webinar today. Also, a big shout out to my fellow panelists, Jennifer, and what I'm sure you will learn is the more high quality Karyn Anderson of the two of us. You guys have been a pleasure to work with, and just appreciate coming together to get to talk about something so important. And lastly, a big thank you to all of you. Way to set the record. We have over 300 people, and this is part of what's really important about this topic, right? Is that people can start to think of equity issues for specific communities as just thinking about a small group of people, and if those people aren't me, they don't matter. And all of us, if we're really going to embrace an equity lens, if we're going to fight for a more equal, just world, we have to think about who's getting left out, who's not being included, and whose voices are often the most resilient, most amazing leaders that can take all of us forward. And so you showing up sends that message. And so from me, from the fellow panelists, thank you so much for showing up. Thank you for saying LGBTQ seniors matter. Openhouse, you can go to the next slide. Openhouse is a nonprofit that was founded in 1998. We were founded really with the goal of let's build LGBTQ welcoming senior housing. But we knew that housing alone would never work because housing is incredibly important. Access to housing is incredibly important. But without services, without changing the community around you, without training and influencing our aging service providers, housing alone won't work. Housing can become another closet if it is the only place that people feel safe. So quickly, our mission became services, community building, and housing. And because housing projects just, move quickly in San Francisco, in 2017, from 1998 to 2017, and I was fortunate to become the executive director right around the time that the founding dream became a reality. Openhouse co-developed and opened a 2-building project with Mercy Housing that now includes 119 units of LGBTQ welcoming affordable senior housing, the first units in the Bay Area that are LGBTQ welcoming affordable senior housing. Our services include a really wide range of things that center the lives of LGBTQ seniors, community engagement, wellness and support, resource and housing navigation. And we're known as a housing organization, and certainly we're incredibly proud and fortunate of our 150 plus residents, but we actually serve about 3,500 LGBTQ seniors across San Francisco and the Bay Area every year. We also knew, again, that just thinking about what happens at Openhouse wouldn't change the community and the culture. So we've been doing cultural humility training for providers for over 20 years. We can go to next slide. So sometimes a question people ask is it really LGBTQ people? How in the world do you do that in housing? You can't discriminate based on sexual orientation and gender identity. And that's right. We don't want to be able to let people discriminate or choose who gets into housing based on their sexual orientation or their gender identity. But in our building, we have about 68% are LGBTQ in our first building and over 55% in our second. And the key to this is really doing things like we're doing today, right? Talking about LGBTQ welcoming, focusing, centering the lives and experience of LGBTQ seniors, working all year round for many, many years around housing access, whether it's in our building or not. All of those things made the difference and are key. Next slide. So you're going to hear me talk a little later about policy and about change. I certainly want to see a lot more LGBTQ welcoming housing across the state. But I want all of us to commit to having intergenerational communities where we center seniors in our lives and in our fight for social justice. And we have to think about how we're going to transform existing aging services to ensure that people can stay in those homes as they age. More to come from that on me later. And with that, I'll hand it to the more high quality and charming Karyn of the bunch. Karyn Anderson, you're on.
Karyn, you're muted.
There we go. Lavender Seniors of the East Bay just celebrated its 25th anniversary of being a community support organization. And we are a group that reached our maturity during the days of Stonewall, and in the 60s. We began identifying ourselves to the outer world as gay, lesbian, transgender, bisexual. And that is who we see ourselves as. The thing about our generation is that the pressure at that time, this was a time of HIV and AIDS, and the pressure at that time was to either defiantly come out as LGBT, we just said gay in those days, or remain in the closet. Our mission at Lavender Seniors was to collectively support each other in our own identities, to feel safe and without the fear of the penalty of arrest, having our children taken from us, even jailed. And of course, now things are so much more open. We go into an alphabet, my friend calls it, of LGBTQI2S. And the difference between the generations is a difference which has taken many of our seniors back into the closet. Our sensitivity and our identity for many of our seniors is a little confused at times. And it's hard to begin to fit in when you're 75, 80 years old. So we have challenges without leaving our room. But the mission of Lavender Seniors is to be able to fully complement each other, to strengthen each other, to help us in our identity, to listen to each other's stories, and to be a support network to reinforce our own identity. Next slide. Now, Lavender Seniors does this through a series of programs. And during the period that we're going through now with the pandemic, many of our programs are on hold or being redefined. Our mission to collectively support each other in daily life is based upon face-to-face assemblies and being there for each other. And of course, with the pandemic, it's necessary for us to shelter in place. We've been defined as one of the most vulnerable communities during this pandemic. And so we encourage our members to shelter in place whenever possible. And we are just beginning, to put many of our programs online to a virtual community. As you can see, the congregate meal program is now online. And those two meetings take place on the third Friday and the second Saturday of the month. And we encourage our participants to bring your own lunch. And we meet at that time and talk about things that are of importance and significant to our community. The Lavender newsletter has hit the ground running without any bumps or thumps. The newsletter can be accessed through our website online, or we will mail a hard copy if we have an individual's request. And number 3, the friendly visitor program. This is what I'm going to talk about today. We have as a goal to reduce isolation of our seniors by actually visiting them with them in our home. We have a core group of volunteers who will spend time with our seniors, both in their home and in residential facilities. Of course, COVID has changed the possibility of all that, and we'll get into that later. We also have the movie series, which we are in the process of reinstituting online, and the speakers panel, which also has been affected by the COVID. Our scrolls, we are adapting ourselves to the COVID in terms of personal appearance. Next slide. And I'm going to pass it on to Jennifer.
Thank you, Karyn and Karyn. So I'm from Legal Assistance for Seniors, and LAS is a nonprofit that serves older adults in Alameda County. We do offer legal services, community education, and individual Medicare counseling. If someone's interested in more information about the legal services we offer, you can check out our website or give us a call to ask questions about what we can do. But I will focus on the health insurance counseling and advocacy program that we run, because that's actually available statewide. So while we run it for Alameda County, it is available in every part of California. The HICAP program provides assistance with Medicare and any other insurance that someone may have that works with their Medicare. We also, so we can provide information about benefits and options. We also help people who are becoming eligible for Medicare. And so if you are working with an older adult who has questions about their Medicare, you can refer them to the HICAP program. If you call the 1-800 number listed here, it will actually take you to the HICAP for your county. So in California, anywhere you are, you can call the 800 number and get connected with HICAP. Next slide, please. So I'm going to dive into some more of the meat of today's topic and talk about LGBT adults as a vulnerable population. The important thing here is that members of vulnerable populations often have health conditions that are exacerbated by unnecessarily inadequate healthcare. There are many listed there, but I think today we're focusing on refusals of service and reluctance to seek care. Unfortunately, refusal of service is a thing that still exists in the world we live in, and reluctance to seek care can often be related to experiences of having, even in the past, had some sort of refusal or fear around service. And so we'll talk more about how that puts older adults back into the closet now that they're aging. Next slide, please. One piece of legislation that came out fairly recently is AB 959, which is the LGBT Disparities Reduction Act. And that act requires 4 specific state departments to collect voluntary, self-identified information pertaining to sexual orientation and gender identity. So that's how it got the SOGI name. And that's whenever any other kind of demographic data is collected. So just like other demographic data, people can choose not to answer the questions, but agencies that fall under the Department of Healthcare Services, Department of Public Health, Department of Social Services, or CDA are required to ask for this information when doing intakes. The department needed to be in compliance by July of 2018. So it is one thing that we at HICAP added to our intake information when we're meeting with clients. We now ask them questions about sex identified at birth, gender identity. And if that sounds confusing, I'm going to define a lot of these terms in just a moment. So stick with me. And then what this does is it collects data necessary to understand the extent of disparities in health and well-being, and whether the government programs are actually reaching LGBT people who are in need of care and assistance. Next slide, thank you. So defining a few things for everyone, just to make sure that we're not saying things that are confusing or nebulous. Sex at birth is the sex assigned by a doctor at birth based on the physical characteristics that they observe at the time of birth. So, imagine the cigar. It's a boy, it's a girl. These are traditional things that we've done, but that may not align with someone's gender identity, which is a person's internal, deeply held sense of their gender. It has a lot to do with societal constructions around gender, how people see themselves functioning in the world. So gender is different than sex at birth. I will admit that one thing that drives me crazy is the name gender reveal parties, because you can't know a baby's gender if it doesn't exist in the world yet. So we're having sex reveal parties, which is fine. If y'all want to rename it that, it would make me feel better. Next slide, please. Okay, some more terms. Cisgender. Some people have not heard this term before. It's a person whose sex at birth matches their gender identity. Transgender is a word that people are probably more familiar with, and that's an umbrella term for people whose gender identity or expression differs from the sex that they were assigned at birth. So transgender people may identify as female to male or male to female, and those usually have an acronym associated with them. Transgender people may or may not decide to alter their bodies hormonally and or surgically. So don't assume that you'll know someone's gender identity based on the way that they appear to you. You want to be able to take the information that they're giving you and honor the things that they're asking to be called, which we'll talk about more in a second. Gender queer or gender non-binary are terms that describe people who may not fit into the conventional idea of one gender or the other as binary. And so they may feel like they are neither gender, both genders, a combination of genders, and it can often manifest in gender neutral pronouns, the use of they and them instead of he or she. It can manifest as gender expression, things like clothing, hairstyle, and jewelry, or in other ways. So the best thing to do when working with a client is just ask them and talk to them. You don't want to assume that everyone who is cisgender will be, that you'll be able to identify that or that they're transgender based on how they appear to you. If a person does identify themselves as transgender or non-binary, follow-up questions you can ask are, what is your preferred pronoun? You could even just drop the preferred and say, what is the pronoun you use? Do you have a preferred name that's different from your legal name? That's really important if you're a provider and you're having to put people's information on forms. They may have a legal name that has to be put on a form, but you still want to work with them and honor them by the name that they want to be called. And then a couple of other things related to this are family of choice, which is that a lot of LGBT people had to find other ways to develop family if they weren't able to maintain their relationships with their friends and family as they came out of the closet. And so their family may not be biological or legally recognized, but if they're telling you that those are the people that provide their social support and their care, you need to find ways to include that as part of their family. And then there's another acronym there, which is SOFA, and that's significant others. Sorry, the chat popped up over it. Friends, family, or allies. And that often is who makes up a person's support system. Next slide. And then just the last few terms here, when we're talking about LGBT, there's all these words floating around. Gay is used to describe anyone, but often men, who have a primary physical, romantic, or emotional attraction to someone of the same sex. So people often say like gay man or gay people. A lesbian is a woman whose primary physical, romantic, or emotional attraction is to other women. So some lesbians may refer to themselves as gay or gay women. But again, terms can vary so much that if a person just calls themselves something, the most important thing you can do is use the term that they use for themselves, because that's obviously what they're comfortable with. Bi or bisexual is someone who may have that attraction to both men and women. Another term that's not on here is pansexual. Some people prefer that because they may be attracted to someone whose gender identity doesn't match male or female. And so there's more variety to say I'm attracted to people versus, a sex or a gender. And then the term queer, which is an umbrella term meant to encompass identities that are not cisgender and or heterosexual. Queer often comes with political connotations. And if you're working with older adults who came of age prior to the mid-70s, this is generally not a preferred term. So for me, I love this term. I use it all the time for my own identity. But I've talked to plenty of older adults who, that word may have been used to tease them or taunt them when they were young, and they don't want to be called queer because it has all these negative associations. So just be aware of that. And again, what people use for themselves, try to use that as well, because it's their comfort zone. And next slide. And then just a couple of things about Medicare. So many transgender people don't have a gender marker on their ID card that matches their gender identity. And that's not a barrier to accessing services with Medicare. Medicare providers may not discriminate on the basis of sex. It's in the section of the Affordable Care Act that prohibits discrimination on the basis of gender identity, and sex-specific procedures and services cannot be denied because your Medicare card or other ID reflects a gender different than your identity. So Medicare does have to approve the coverage of the services that are medically appropriate for the patient. For example, an older adult who now identifies as female to male, so someone who was identified female at birth and identifies themselves as a currently in the gender of being male, they may need services for internal female organs that they still have, even though their presented gender identity is male. Well, Medicare has to cover that. And so you have to make sure, if you have problems with your clients or they need any assistance with this kind of stuff, please send them over to HICAP so we can help them. They can also always call Medicare. But there's a specific code Medicare has to approve that situation. And that's condition code 45 that will tell them do these services because it matches the person's body parts. And Medicare Advantage plans or Part C plans and prescription drug plans can't use that code. So if there's an issue there, call HICAP so we can help get the person the services that they need. We can help if there's a denial from Medicare or if someone needs to appeal. And if someone is denied coverage, then they can file a complaint with the office, the HSS Office of Civil Rights, and the email address and phone numbers are there. I'll take this time to also just say these slides will be available. So even if we're going through them quickly, don't worry that you won't be able to access websites or phone numbers later, because you can access the slides. Next slide, please. And the last slide for me. Since May of 2014, Medicare no longer bans gender reassignment surgery. It is still on a case-by-case approval basis. Beneficiaries who were denied prior to May of 2014 can appeal or apply again. Medi-Cal usually approves the same procedures as long as Medicare has approved something first. And Medicare does not cover many transition-related drugs, so that's something to be aware of. Many drugs prescribed for gender transitions are considered off-label, which means that they have not been approved for that use by the FDA, and Medicare can't cover off-label medication. And so that's why those drugs are not covered. But if someone has questions about Medicare or any Medicare-related things, especially for your older adult LGBT clients you may be working with, we, any HICAP is happy to get involved and help your clients. Thank you. So back to Karyn Anderson. And Karyn, make sure you unmute yourself.
There we go. Speaking of LGBT seniors and going back into memory, there we go. Going back into our memory, we remember the 70s and the 80s. We remember going back to a time in which the civil rights movement had gotten the everyday person involved in politics. In those times, collectively, LGBT people would collect in bars and clubs so they could meet and greet each other. But they could become subject to arrest. I remember myself in Chicago, which is my hometown. I remember being at a couple of venues and they were raided for no reason other than the fact it was a collection of LGBT people. Now, This was before the 1969 Stonewall action. And so basically what they would do is come in, clear the place out, and close the business down for the day or two. Sometimes the proprietor would be ticketed, sometimes not, and it was very much left up to the personality of the arresting officers. Sometimes you just get a pass, don't let me see you around here again. Sometimes you would actually be taken to the station house. At that time, I was employed in the government. And so I was always fearful of not only arrest, but also of losing my job. Teachers could lose their job. Children could be taken from them. Beside the fact that LGBT people were shamed and traumatized and very afraid to come out of the closet. So for most of their adult lives, many of the individuals who we now call senior have in one way or another had to deal with their identity. And some have had to experience major clinical depression. Back in the days of the 60s, 70s, even early 80s, LGBT people were considered to have a psychological problem. And of course, that made them crazy, that made them um, mentally unstable, emotionally questionable. And many of our community believed the hype. It did not necessarily lay the foundation for a healthy senior life. And so self-imposed isolation often made things worse. Self-loathing. Many of our people have tried to commit suicide. They reverted to alcoholism, substance abuse, as well as physical abuse. Some have been fired. And this is the history, this is the memory of the individuals that are today senior. It's no wonder that our people are suspicious of institutions and the government in terms of acceptance. Next slide. Now, as we age, we become more vulnerable. And this is true of the entire senior community, regardless of their sexual identity. We're more likely to stay in the closet. And what the COVID has done is only to exacerbate exactly what we have gone through all of our lives. And so the majority community now can understand the feeling of isolation that brings depression, the discomfort of being in a long-term care facility and the vulnerability that it brings. Many of our people have a history of being HIV positive, and they have lived their entire lives with what was a stigma, now which is just a medical condition. The one thing that everyone has in common is that we are all aging. And that's something that Wendy Peterson of the Senior Services Coalition likes to remind us. We are all aging regarding. But speaking about getting older and facilitating taking care of ourselves is not something that we're taught in school. We may be required to learn a squared plus b squared equals c squared, but we are not taught how to write a check. We are not taught what is Social Security and how do I qualify? What happens when I don't? No one is eager to talk about death and dying and that period before it. This is a confrontation which our community has to face daily. Next slide. In 2017, the Social Security Administration said that it would reopen any decision denying spousal or survival benefits. Now, take that backwards to the passage of the same-sex marriage and understand that this was a time not too long ago when gay people, for the first time, could have legal acknowledgement of their relationship status. I remember that in 2015, everyone was so excited by the passage of the legal right to marry. But there were also many LGBT people who felt that they did not want to take advantage of legitimate legal marriage, that it was too parallel to a straight, quote unquote, definition of getting along in society. And so there became a reaction to the legal right to marry. The thing that Jennifer was pointing out is that there are many interpretations and many facets of this thing that we call gay, LGBT relationships. And it brings up a lot of personal history for a lot of people. The, excuse me, the high turnover rate within SNFs, nursing home, has many of our people very sensitive about who knows what about them. Privacy becomes a matter. You may trust one person with your information and they could be gone the next day. I have a client who was having some problems and felt that she was being disrespected in her nursing home. I asked if she wanted us to go to the ombudsman and formally look into the situation. And she made it very clear, no, I don't want the ombudsman involved because once you and the ombudsman leave, I'm here alone with these staff members. And nobody can help me at 11 o'clock at night if they decide they don't want to change my diaper or bring me my meal late. And so the vulnerability of our group, our classification, is a daily challenge. Next slide. So in the past, we've been largely invisible, and a lot of that was as a measure of self-protection. There's a scarcity of programs and services that specifically serve our community. And so on an individual basis, we decide whether or not to interact with organizations, services, or government programs that indicate they are there for us. But the number of people in our category of senior status has grown and is swelling. And despite all the woes of getting older, our numbers will continue to swell. But we are even more vulnerable health-wise to everything that goes on in the majority community. And so there's a experience of the old homophobia and anti-gay bias. And we can just look at the present administration and how subtly the government began to discriminate against us, and very often do it without leaving a fingerprint. Next slide. So studies, of course, have shown that many of the experiences of our community puts us at high risk for isolation and poverty and homelessness. Many of our people find that this is not a good time to look for housing, to look for community support during this period of physical decline. I have a client whose health has deteriorated to the point that they can no longer physically take care of themselves, and they need a caregiver. Even though they've been married for 22 years, the health of both individuals are such that they can no longer physically take care of each other. And so the decision has been made to separate and try and find separate housing where they can also receive caregiving support. These are the kinds of situations and problems that are unique to the LGBT senior community. And we're very, very happy that HiCap is there to help us wind our way through the bureaucracy of getting older physically. But we still have the situation of getting older emotionally. Next slide. In the good old bad days, we had and discovered and created the MCC, where spiritually our members could go and be in a like-minded congregation. For all of us, we understand that there are outlets for our community, but again, not enough. Not enough. And the designation of who we are and how we conduct ourselves towards acceptability has always been a factor. Next slide. It's essential that we, that we ensure that the sexual orientation and gender identification that Jennifer mentioned be collected. I have no idea how the census information that was recently collected will be used to help support who we are. There really weren't enough questions to help us know who we are, where we are, and what our needs are. But that's another subject.
Hey, Karyn, I'm going to jump in and tell you this is the transition slide back to Karyn.
Right. Karyn, I see you.
Hey, from
Go.
one Karyn to the other.
One Karyn to another.
We're reestablishing, I hope, a little bit of good association around our name. But I mean, not much, but I think we're doing good work today, Karyn. Just a little bit. You mostly.
Just a little bit.
I'm just cheering you on. Yeah, thank you so much. That was really just really powerful information. I've been looking. We're seeing questions in the Q&A and the chat, and we're going to try and answer as many of those through the chat and through the Q&A, but I'll also try and sort of move pretty quick through the policy and advocacy work stuff here. So we have about 10 minutes at the end for questions and chat, but feel free to put questions and chat in the Q&A and the chat function. If we run out of time today, I know we're all committed to following up on information outside of today as well. So yeah, the issues become a lot of what you're hearing about, and that Jennifer and Karyn did such a wonderful job talking about was, what can we as individual providers, what can we as individual people working in aging do as we're working and supporting our LGBTQ clients? And that's really important. And if we don't change the landscape of aging services itself and housing, each of us as individual providers won't be able to make the impact and the changes that we really need to serve LGBTQ seniors. So you've heard a lot about the SOGI legislation that got it put into place. San Francisco did local legislation before there was the state legislation. And what I'm going to tell you is, while the legislation exists around SOGI data, we've got a long way to go in terms of actual compliance and collecting that data. That's true in San Francisco, where sometimes people think magical things happen for LGBTQ people. I'll just tell you that's not true. We've got some things we do well, but no magical unicorns or fairy dust, right? So even there, we're still working on really getting accurate data. But I cannot emphasize enough how important this data is, because without it, we can't talk about what people need or don't need. We can't talk about what's working and not working because we don't know where LGBTQ people are. So one of the most powerful things that have come out of us pushing in San Francisco to really have this data is that for the first time, we were able to show, look, LGBTQ seniors are dramatically underutilizing services in San Francisco. We couldn't show that without SOGI data, but we now have data that shows that LGBTQ seniors are 2 to 10 times less likely in San Francisco to access eligible aging services without a fee being provided through city funding than their heterosexual and cisgendered peers. It's particularly dramatic with transgender seniors. So SOGI is so critical because without it, it's very hard to change policy, to make a case. Someone asked a question, are men more likely to be closeted than women? The whole problem is we don't know. That's the problem with being closeted, is we don't know where people are. So one thing we could say is maybe people aren't underutilizing services. Maybe they're just utilizing services, but not telling anyone that they're part of the LGBTQ community. So everything we can do, if there's anything you walk out of here today, if you're getting forms, I saw this in the chat, that don't have the right information, let's push back on those forms. If you're doing assessments and you realize sexual orientation and gender identity aren't included, let's raise a hand and say we got to figure out how to do that. It's really hard work. It takes shifting, it takes training on knowing how to ask the questions. Openhouse does some of that training. I'm sure CDA and Lavender and other places can support you in that, but it's critical. We need a lot more affordable LGBTQ welcoming senior housing, and it's got to be done with smart local policies based on how your housing works in your individual city or location. I'm going to just say that and assume we can nod, and we could do a whole another 3 hours on housing. But if you build housing and you have no good services for long-term care, right? Services that are designed to keep you in your home, even if you become frail, even if you develop dementia, even if your partner, who's your caregiver, passes away, we've now set up people to have these wonderful welcoming homes and then have to leave for assisted livings and nursing homes where people are very likely to move back in the closet. So we got to think about services too. that underutilization of services that I talked about becomes more dramatic the more dependent the care setting is. So we see very, very low numbers of LGBTQ people in places like social day programs, adult day healthcare, PACE programs, adult assisted living, nursing home, right? Anywhere where care is dependent, we see very, very tiny numbers of LGBTQ people. So either they're not getting care or they're not out. Both are a problem. You can go to the next slide. The thing I just wanted to add is, marginalized populations, populations who face discrimination, who face barriers to care, LGBTQ people who are also part of communities of color, LGBTQ people, specifically the trans community, right? One of the things we know is that trauma, discrimination, being treated like crap by other people, racism, all of those things tend to contribute to people aging at a faster rate. So for example, many of the trans seniors who we work with say they consider themselves a senior if they reach the age of 30 or 35. We have a lot of trans seniors who access open house programs who are 50. And we look at our aging services, right? And what is the age limit that's set up? 65. So we've got a gap there, particularly for the people from more marginalized group, the people who have experienced more trauma over their lifetime in terms of access and care. We got to get away from age limits and think instead about eligibility around health status or eligibility about people identifying as senior. So we got to think that way. The Bill of Rights for long-term care settings, great legislation that passed. It's about, really trying to protect and support people in assisted livings and nursing homes. It's great. It requires putting up a Bill of Rights specifically that speaks to LGBTQ people. It asks for training in those settings. But I'm going to tell you, we've got a long way to go on implementation around that as well. We're doing some of it in San Francisco. We still have a long way to go there. And we have a real challenge across the state, which is a lot of our nursing homes are overflowing, right? We don't have enough space. And because of that, when people aren't motivated to make sure to serve as many people as they can because they're already overwhelmed by the number they're serving, it's much harder to get people to think about equity issues. So we're going to have to think wisely about what actual implementation and behavior change looks like, rather than just the beginning, which is an important start of here are your rights as a queer person or as an LGBTQ person in a nursing home. Go back 1 second. The master plan is coming out. It's already going to be amazing in terms of LGBTQ seniors. There's been good integration between those of us doing the care and master plan. And we're going to have to be careful that we don't assume that services that are in there will work for LGBTQ seniors, because again, the beginning data we have now shows us that LGBTQ seniors have not been accessing or have not been out in a lot of these service models that we've been using to deliver care. So Open House is working to change that. We're partnering with deep partnerships that are transforming, we hope, traditional aging care, including OnLock and their PACE program, thinking about social day. We have a partnership with an ADHD, right? How do you really change care? But I can tell you from that work, it's going to take a fundamental foundational shift. It's not we do a 2-hour training and everything's fixed. But it's fun work. It's amazing work. And I think to that point, we want to think about not just funding for services, but how do we fund bridges? How do we fund the access to care for people, right? So sometimes we do a good job in saying, we're going to fund, new social day programs for LGBTQ seniors. That would be great. But what really needs to be funded is we're going to fund access to care programs that are going to help people from marginalized groups beyond LGBTQ, right? People of color, people from Black communities, trans communities, our Native American indigenous communities, right? How are we going to really build access to care? What would it take for people to feel safe even making the call to walk through the doors to a program, rather than just saying, we're only going to fund and support once you walk through the doors? Because we know people walking through the doors through an equity lens, we're not getting everybody through that path. And lastly, LGBTQ people, we as a community tend to be very ageist. And because of that, you'll often see LGBTQ policies that are written very much imagining a younger LGBTQ person. We write policies for LGBTQ people, and they would never work for someone who's a senior. And so again, not only do we need to transform traditional aging services, we've got to transform the way LGBTQ organizations and care and policy works, such that it imagines LGBTQ people at every age, not just as younger people. So I moved pretty quick. We got 5 minutes left for questions. I'll go to the next slide. I'm going to skip this slide for now, and we can leave the resources up. So this is some of the folks you've heard about today. Lavender, Openhouse is there. SAGE is a national organization who we work with closely, who does housing and services. The National Resource on LGBTQ Aging has a lot of great stuff that's up there. You're welcome to contact us to help you go through the path. And we can go to Q&A now.
Yeah, go ahead, next slide. So if anybody is on the phone and needs to raise their hand, hit that *9. Otherwise, we can scroll through the chat and see if we've missed any questions so far. And I'm seeing a lot of comments.
There are no LGBTQ, there are no skilled nursing facilities currently who identify themselves as LGBTQ welcoming. So Annette, you aren't just not finding them, they're not there yet. Jennifer, did you want to take on some of the questions that came up around specific Medicare coverage for trans people?
Yes, and they're complicated questions. So I'm actually thinking that in the time that we have, it doesn't make sense, but we can save these and I can respond to people after the webinar with more information.
That'd be great. And if people want to send these comments to the engage@aging.ca.gov email on this slide, we can then forward them on to Karyn, and Jennifer, or try to get you answers ourselves as well. But we have saved that. We'll save this chat box and try to reach out via email on our lists. So do we see any questions coming up? No.
There's so many good questions. I will say, one asked if I'm available for virtual workshops. Yes, and the agency I work for serves Alameda County. So if it's outside of this, I'd be happy to try and find someone else who could do it, or see if it's something that we could do if it's like close to Alameda County. But there's so many great questions here. So please send them in and we'll try to get back to everybody.
Okay, and Nancy, I see 2 raised hands. Could we allow those folks to ask their questions? Oh, now I see 3. 2. Oh.
Also, this is being recorded. I see that question coming up in the chat. This is being recorded, so people will be able to access it again.
Great, and all of the hands then went down. All right, well, I think we should wrap it up. We've got 2 minutes left, and I just want to thank all of you so much. The questions, the comments in the chat box were amazing. Lots of positive feedback. It's just so obvious we need to create more content like this. It's just so needed in this community. I do want to encourage everyone to sign up for next month's webinar on culturally responsive services and care with and for Black elders. We have 3 speakers joining us for that one as well, with a breadth of experience in policy, health equity research, as well as behavioral health. And again, following up with an email with all of the resources from this webinar today. Please check out, if you go to CDA's homepage, you can see the California for All Ages button, and they'll take you to the Equity and Aging Resource Center. We've got lots of social media kits, things you can use to post and promote this sort of information. And also this is recorded, so we had a really high registration rate and turnout rate, but we'd love to have you share this and get this out. It's a great resource for everybody. So again, thank you to my speakers. You were phenomenal. Pleasure to work with you. And everyone out there, just take care of yourselves, take care of each other, and we hope to see you next month. Bye.